Welcome to the Deep Dive. Today, we're going deep on a topic that's pretty crucial to modern medicine.
It is,
We're
yeah.
talking about neuromuscular blocking agents,
Hmm.
NMBAs for short.
Hmm.
They're these drugs that make it possible for surgeons to do their thing.
Right. They induce muscle relaxation, which is, well, I think most people can picture why that's important for surgery.
Absolutely. Can you imagine trying to operate on someone whose muscles are all tensed up?
Yeah, it would be pretty impossible. And not just impossible, but also dangerous.
Yeah, good point. So we've got a fantastic resource for this deep dive, the Anesthesia Academy's chapter on NMBAs. It's dense, but it's packed with insights.
It is a really good resource, very thorough.
Okay, so let's start with the basics. What do these NMBAs actually do? Like at the microscopic level, how do they work?
Well, to understand that, we have to think about how our nerves talk to our muscles.
Okay, yeah, walk me through it.
So, picture this. You've got a nerve impulse. It travels down to the nerve ending, and that triggers the release of acetylcholine.
Oh, I've heard of that.
Right. And A key is like a key. It fits into specific receptors on muscle fibers.
Like a lock and key mechanism.
Exactly. And when AT unlocks those receptors, the muscle contracts.
Makes sense. So where does the blocking part come in?
Well, there's this enzyme, acetylcholinesterase, AT.
I remember that from med school.
Yeah, well, AT acts like an off switch. It breaks down AT, and that ends the contraction.
So it's like a carefully choreographed dance, nerve impulse, AD release, muscle contraction, achy cleanup.
Precisely. And this is the system that NMBAs disrupt. They interfere with that whole process.
And speaking of disrupting, the Anesthesia Academy mentioned that our bodies actually release way more AT than needed.
Yeah, that's right. It's kind of like a safety margin.
Like our muscles are primed and ready to go.
Exactly.
Okay, so NMBAs mess with this well-oiled machine. How do they do that? Aren't there different types?
There are, yeah. You've got your depolarizing agents and your non-depolarizing agents.
Okay, let's start with the depolarizing ones. I know one of the most common is acetylcholine. How does that work?
Acetylcholine is basically a copycat key. It mimics a She.
So it binds to the same receptors.
Yep. But here's the thing. Acetylcholine doesn't break down quickly. It hangs around.
So it keeps the muscle contracted.
Exactly. Prolonged contraction, and eventually that leads to paralysis.
So it's tricking the muscle into a sustained contraction, essentially freezing it.
That's one way to put it. And because it acts so fast, acetylcholine is really valuable for, say, emergency intubations.
Makes sense. But I'm guessing there are some downsides, right?
There are, yeah. One risk is hyperkalemia.
High potassium levels, that can be dangerous.
That could be, yeah.
Yeah.
So careful screening is vital. We need to know who's at risk before we give it.
Makes sense.
Ooh.
And I know there's another rare but scary risk with acetylcholine, malignant hyperthermia.
Right. And one early warning sign of that can be mass tremor muscle rigidity. Like the jaw muscles get really stiff.
So it's definitely a high-stakes medication.
It is. We also have to be aware of things like the dibucane number. It basically tells us how someone will metabolize the drug. It's a genetic thing.
So even if two people get the same dose, their bodies might handle it very differently.
Exactly.
Okay, so acetylcholine is the speedster. Fast-acting, but with some serious potential risks.
Right.
What about the other type of NMBA, the non-depolarizing agents?
These guys work differently. They actually block their receptor completely.
Like they prevent AC from even getting in there.
Exactly. Think of it like putting tape over a keyhole. The key AC can't even get close.
That's a great analogy. So if the on signal is completely blocked, how do they ever reverse the effects?
That's a great question, and we'll dive into that a bit later. But the cool thing about non-depolarizing agents is that there are so many different options. We've got short-acting, intermediate-acting, long-acting.
Wow, so there's a whole toolbox of non-depolarizing agents to choose from.
Exactly, and each one has its own advantages and disadvantages.
This is getting really interesting. So tell me more about these non-depolarizing agents. What are some of the key differences between them?
Well, let's start with atracurium and cisatracurium.
Oh yeah, those are the ones that are good for patients with liver or kidney problems, right?
Exactly. They break down through a process called Hoffman elimination. It doesn't rely on the liver or kidneys.
That's pretty handy. So it's a safer option for those patients.
Yeah.
Are there any downsides to using atracurium or cisatracurium?
Well, with atracurium, you have to watch out for histamine release.
Histamine, like the stuff that causes allergic reactions.
Yep, that's the one. It can cause a drop in blood pressure or even bronchospasm in some patients.
That sounds a little scary.
It can be, but we monitor for those reactions very closely. Cisatracurium is actually much better in that regard. It releases far less histamine.
So cisatracarium is the safer of the two.
Generally speaking, yes.
Okay, what about some of the other non-depolarizing agents? The Anesthesia Academy chapter mentioned mibacurium. That's a short-acting one, right?
It is, yeah. It's even shorter acting than succinylcholine. Really good for quick procedures.
Wow, even faster than the speedster. What's the catch?
Well, just like with succinylcholine, its breakdown is influenced by those genetic variations we talked about earlier, the ones affecting the plasmacolinesterase enzyme.
So again, personalized medicine is key. Got to know your patient.
Absolutely.
Okay, what about the aminosteroid group? Vecuronium, rocuronium, pancuronium. Those are all non-depolarizing, right?
They are, and they each have their own unique characteristics. Vecuronium is very stable, for example.
Stable. What does that mean in this context?
It means its effects are very predictable. It doesn't cause big swings in things like heart rate or blood pressure.
So it's a good choice for patients who are already a bit unstable.
Exactly. Patients with conditions like pheochromocytoma, for example.
Okay, makes sense. What about rocuronium? That one's interesting, right? It can be used for both routine intubations, A&E rapid sequence induction.
Yeah, rocuronium is pretty versatile. If you give a high enough dose, it can work almost as fast as succinylcholine.
Wow, that's impressive. But I'm guessing there's a trade-off. If it's faster acting, does it also last longer?
You're right. The trade-off is that it does have a longer duration of action compared to succinylcholine. So if you need really rapid recovery, it might not be the best choice.
Okay, so it's a balancing act.
Always.
And then we have pancuronium. That's the long-lasting one, right?
It is. Pancuronium is eliminated mainly by the kidneys, so if someone has kidney problems, it can stick around for quite a while.
So again, knowing your patient is key.
Absolutely crucial.
Okay, so we've got this whole range of non-depolarizing agents, each with its own personality.
That's a good way to put it.
But how do anesthesiologists actually monitor the level of paralysis? How do they know if it's enough for the surgery but not too much?
We use a technique called peripheral nerve stimulation. Basically, we deliver little electrical impulses to a nerve.
Like with a little zapper?
Kind of, yeah. We usually do it on the hand or foot, and we watch how the muscles respond.
So if the muscle twitches strongly, it means the blockade isn't very deep.
Exactly. And if there's no twitch at all, well, that means we've got a deeper level of blockade.
Makes sense. The Anesthesia Academy chapter mentioned different patterns of nerve stimulation too, like single twitch, train of four. What are those all about?
So a single twitch is just one electrical pulse, but it's not very sensitive, especially for detecting any residual blockade after surgery.
Residual blockade, like when there's still some drug hanging around.
Exactly. That's where train of four comes in. TOF, for short. We
Yeah.
give 4 stimuli in quick succession, and we look for fade.
Fade. What does that mean?
It means the height of each twitch gets progressively smaller. So the first twitch might be strong, but the fourth one is much weaker.
Interesting. So the more fade there is, the more blockade there is.
Exactly.
Right.
You can even quantify it with the TOF ratio. It basically compares the height of the fourth twitch to the first.
So ratio of 1 means no fade, right?
Yep. No fade, no blockade.
Pretty clever.
Yeah.
What about tetanic stimulation? When would you use that?
Tetanic stimulation is a continuous burst of stimuli. It's not used as often because it can be a bit uncomfortable for the patient.
I can imagine. So you only use it in special cases.
Yeah, if we need to assess a very deep blockade, or if the TOF results are unclear. We also use double burst stimulation sometimes, which is kind of a hybrid of TOF and tetanic.
Wow, so many different ways to monitor these drugs.
It's all about finding the right tool for the job.
Makes sense. Okay, we've talked a lot about the general principles of NMBAs, but I'd love to get into some special considerations. For instance, are there unique challenges when using these drugs in children?
Absolutely. Children aren't just little adults. Their bodies handle drugs differently.
So you can't just give them a smaller dose of the adult medication
Nope, it's not that simple. For instance, we generally avoid succinylcholine in kids.
because of the hyperkalemia risk?
Exactly. Kids are also more susceptible to certain complications, like malignant hyperthermia.
And I imagine you have to be extra careful to rule out any underlying conditions that could make things more risky.
Right. Things like undiagnosed muscular dystrophies, for example, that can really increase the risk of complications.
So even more caution is needed with kids. What about non-depolarizing agents in children? Any special considerations there?
Yeah, their onset and duration can be quite different compared to adults, especially in neonates.
Neonates, you mean newborns?
Yep, the tiniest humans. Their systems are still developing, so drugs can act very differently.
So you really have to adjust the dosing very carefully.
We do. And we have to be mindful of drugs like vecuronium, which can last much longer in newborns than in older kids or adults.
Wow, so many things to keep in mind. It seems like anesthesia for children is a whole other specialty.
It really is. It requires a very specific set of skills and knowledge.
What about elderly patients? Are there any age-related factors that influence how you use NMBAs?
As we age, our organs don't work as efficiently. That includes the liver and kidneys, which are responsible for breaking down and eliminating a lot of drugs.
So NMBAs might stick around longer in older patients?
That's right. And that means a higher risk of prolonged effects, which could lead to complications.
So you have to adjust the dosing and be extra vigilant with monitoring.
Exactly. And again, cisatracurium often shines in these situations because its clearance is less dependent on organ function.
Cisatracurium is really proving to be a versatile drug. What about pregnant women? Any specific concerns about using NMBAs during pregnancy?
Most NMBAs are considered safe to use during pregnancy, but of course, we always want to minimize drug exposure to the fetus.
Of course, so you use them judiciously.
Exactly. Acetylcholine is one we're particularly cautious with because of that hyperkalemia risk, and pregnant women are already slightly more prone to hyperkalemia due to hormonal changes.
So it's a delicate balancing act, weighing the potential benefits to the mother against the risks to the baby.
That's right.
Are there any other patient groups that require special consideration when it comes to NMBAs?
Definitely. Obesity is another big one. We have to adjust the dosing to account for the larger body mass.
That makes sense. But I bet there are exceptions to that rule, too.
You know it. Cisatracurium, once again, kind of breaks the mold. Its clearance isn't affected as much by weight.
Cisatracurium, the rebel of the NMBA world. Okay, what about patients with specific health conditions, like liver or kidney disease?
Absolutely. Those are major considerations. For liver disease, atracurium and cisatracurium are our go-to options because they don't rely on the liver for breakdown.
Makes sense. What about kidney disease?
Well, pincuronium is definitely off the table in those cases. It's almost entirely eliminated by the kidney.
It was just build up in the system.
Exactly. And even drugs that are primarily metabolized by the liver, like vecuronium and rocuronium, we have to use cautiously because they can stick around longer if the kidneys aren't functioning well.
So it's not just about one organ, it's about understanding the interplay of all the body's systems.
Yes, exactly.
What about critically ill patients? Are there any unique challenges in using NMBAs in that setting?
Critically ill patients are often on a whole cocktail of medications, so drug interactions are a major concern. They're also more vulnerable to side effects from NMBAs.
What kind of side effects?
Things like muscle weakness and even nerve damage, especially with prolonged use.
So the stakes are even higher in those cases.
They are. We have to be incredibly meticulous with our decision-making, monitoring, and adjustments.
I can only imagine the level of expertise required to navigate those situations.
It's definitely a challenging area of practice.
Okay, let's shift gears and talk about what happens after surgery. How do you ensure those muscles start working again once they're no longer needed?
That's where reversal agents come into play.
Reversal agents. Tell me more.
We've got two main types, cholinesterase inhibitors and Shermadex. The cholinesterase inhibitors, like neostigmine and edrophonium, work by increasing acetylcholine levels.
So they boost the on signal to counteract the blockade.
Exactly.
That's pretty ingenious.
Yep.
But I read that cholinesterase inhibitors can have some side effects. What are those?
They can cause what we call muscarinic side effects, things like a slow heart rate, increased salivation, sometimes even bronchospasm.
Because they're increasing acetylcholine throughout the body, not just at the neuromuscular junction.
Exactly.
So they can be a bit tricky to use, especially in patients who already have certain conditions.
That's why we often give anticholinergic drugs along with them, things like atropine or glycopyrrolate.
To counteract the side effects.
Exactly. It's like giving a counter-medication.
So it's a two-pronged approach. Reverse the NMBA, but also prevent the side effects of the reversal agent itself.
Precisely.
What about Sugamadex? How does that fit into the picture?
Sugamadex is a whole different animal. It actually targets specific steroidal NMBAs like rocuronium and vecuronium. It basically encapsulates them and removes them from the body.
Wow, so it just grabs them and pulls them out?
Pretty much. And it doesn't have those muscarinic side effects, so it's much cleaner. It also works much faster than the cholinesterase inhibitors.
So it's the express lane for reversal.
You could say that.
Are there any situations where Sugamadex is particularly useful?
Oh, absolutely. Emergencies, for example. Or for patients with difficult airways where rapid recovery is essential.
Makes sense. But I'm guessing it has its limitations too.
It does. It only works on those specific steroidal NMBAs, and it's more expensive than the cholinesterase inhibitors.
So the choice of reversal agent depends on the situation and the specific NMBA that was used.
Exactly. It's all about weighing the pros and cons.
Okay, you've walked us through so much. The different types of NMBAs, how they work, how you monitor them, how you reverse them. It's a lot to take in.
It is a complex topic.
Before we wrap up, I want to circle back to monitoring. What are some of the key things you're constantly keeping an eye on throughout the whole process?
Well, first and foremost, we're monitoring vital signs. Heart rate, blood pressure, oxygen saturation. We need to make sure the drug isn't causing any problem.
Of course, safety first.
Always. And since these drugs can paralyze the muscles we use to breathe, we have to make sure the patient is adequately ventilated.
So either with a breathing tube or with a ventilator.
Exactly. And we continue monitoring neuromuscular function even after we've given the reversal agent.
To make sure the muscles are fully recovered.
Exactly.
It sounds like vigilance is key throughout the entire process, from the moment you give the NMBA to long after the surgery is over.
Absolutely. We have to be constantly aware of what's going on and anticipate potential problems.
You've painted such a vivid picture of the complexities involved in using these drugs safely and effectively. But what about some of the bigger picture considerations? Are there any ethical dilemmas that arise when you're using drugs that essentially paralyze patients?
That's a really important question. And the answer is yes, there are definitely ethical considerations. After all, when someone is under the influence of NMBAs, they can't move or communicate.
So informed consent is crucial.
Absolutely. We need to make sure patients understand the risks and benefits before we give them these drugs. And it's not just about signing a form, it's about having a real conversation.
So the patient feels empowered to make decisions about their own care.
Exactly.
What about emergency situations, when there's no time to get consent?
In those cases, we have to rely on the principles of beneficence and non-maleficence.
Meaning you're acting in the patient's best interest.
Exactly. We would only use NMBAs if they were absolutely necessary to save the patient's life or prevent serious harm. And we would carefully document our reasoning.
So it's a heavy responsibility, but one that you take very seriously.
We do. It's not a decision we make lightly.
Okay, before we move on to any final thoughts, is there anything else about the practical use of NMBAs that you think our listeners should know? Any other nuances or challenges that come to mind?
One thing that's really important to keep in mind is the impact of temperature.
Temperature, like the temperature in the operating room.
Exactly. Hypothermia, so low body temperature, can actually make certain NMBAs last longer.
Oh, wow, I didn't know that. Why is that?
Well, it's a bit complicated, but essentially the cold slows down the enzymes that break down those drugs, so they stay in the system longer.
So it's like those enzymes get sluggish in the cold.
Kind of, yeah. It's something we have to be particularly mindful of during long surgeries, where there's a higher risk of the patient getting cold.
Makes sense. So much for cold hands, warm heart, right? At least in the OR. Okay, so we've covered a lot of ground here, the past, the present of NMBAs. But what about the future? Any exciting developments on the horizon?
Oh, there's definitely a lot to be excited about. One area that's really promising is the development of even more selective NMBAs.
Selective. What do you mean by that?
Well, right now, most NMBAs kind of block all the acetylcholine receptors. But what if we could create drugs that only target specific receptors?
So you could fine-tune the paralysis.
Exactly. Imagine a drug that only paralyzes the diaphragm, for example.
So you could ventilate a patient without paralyzing their entire body.
Precisely. That would be huge. It would minimize a lot of the risks associated with prolonged muscle inactivity.
Wow, that would be a game changer. Are researchers working on anything like that?
They are, yeah. It's still early days, but there are some really interesting leads. Another area of active research is the search for new reversal agents.
Even better than Sugammadex.
Well, Sugammadex is pretty amazing, but it only works on certain NMBAs. What if we could develop a universal reversal agent?
One that works on all of them.
Exactly. That would revolutionize the field. No more worrying about which reversal agent to use. No more waiting for the drug to slowly wear off.
It would be like an instant undo button.
Exactly. It's a long way off, but it's definitely a goal worth striving for.
It sounds like the future of NMBAs is bright, lots of potential for innovation.
It is, yeah. And it's not just about new drugs. There's also a growing focus on pharmacogenomics.
Pharmaco what now?
Pharmacogenomics. It's basically the study of how individual genes affect drug response.
So like how your DNA influences how your body handles medications.
Exactly. Imagine being able to analyze a patient's DNA before surgery and predict how they'll respond to different NMBAs.
Wow, that's incredible. So you could choose the safest and most effective drug for that specific patient.
Precisely. Personalized medicine at its finest.
That's really amazing. It seems like we've only just scratched the surface of what's possible with these drugs.
We have. The field is constantly evolving.
Well, I have to say, I've learned so much today. This has been a fascinating deep dive into the world of NMBAs.
It's been a pleasure sharing this journey with you.
Before we sign off, I want to leave our listeners with a final thought to ponder. We've talked a lot about personalized medicine, considering factors like age, health conditions, even genetics. But what if we could take that even further and develop NMBAs that were tailored to specific surgical procedures?
That's an interesting thought. So instead of just considering the patient, we'd also consider the surgery itself.
Exactly. Imagine having NMBAs designed specifically for delicate neurosurgery or high-risk cardiac procedures or even minimally invasive techniques. You could fine-tune the muscle relaxation to the precise needs of each surgery.
Wow, that would be incredible. It would really open up a whole new level of precision and safety.
It's a bold vision, but I think it's worth exploring. It just shows how much innovation is still possible in this field.
Absolutely. It's a reminder that we should never stop pushing the boundaries and looking for ways to improve patient care.
Well said. And on that note, we'll wrap up this episode of The Deep Dive. Thank you so much for joining us on this exploration of neuromuscular blocking agents.
It's been a pleasure.
We hope you've gained a deeper understanding of these powerful drugs and the vital role they play in modern medicine. Until next time, keep exploring, keep learning, and as always, stay curious.